more minutes.
Okay, thank you for
Yes.
starting the recording. Well, we'll lose people at the beginning or we'll lose people at the end. And the beginnings, I just lose my introduction, which is the least important. So how about we get started, Smita?
Okay, we have 33 people.
Okay, Suleiman is here. All right.
Yeah.
So good afternoon, everybody, or good morning in some cases. Thank you so much for joining us for this webinar, which has been a labor of love with my partner in crime, Smita, and the help of Christine, our demand generation intern. So I don't have any slides to introduce because I haven't done a full year at Gavi, so I don't know how to make slides yet. But you all know about Gavi 5.0 and our passion for strengthening routine immunization systems in a way that puts equity first, that reaches zero-dose children. And we all know about the IRMA framework, identify, reach, measure, monitor, and do advocacy. And we've spent already a lot of time, thanks to our SMI team, MSI team, and our equity colleagues, thinking a lot about identify, and a lot of work needs to happen. And today we want to start bridging the gap, the kind of potential gap between identify and reach. First, I'm very rude, I should have introduced myself. I'm Eric Sario. I'm a recent addition in the last year to the HSIS team, and I'll say something about our speakers in a minute. And Smita Singh is our senior demand generation specialist expert. And as I said, we worked on this together. So back to the topic. I'm not great at protocol, apologies. So we want to look at going from identify to reach. And we know that sometime zero-dose children and communities can be clustered, for example, large displaced groups and so forth. But sometimes also zero-dose children can be lost in the crowd. They can be disseminated or scattered. And we want to start looking at ways to reach that really kind of help us in these situations and different contexts. And we want to look at not just identification, but we want to look at ways that communities themselves can be put in a driver's seat, have a key role as part of the health system, and where impact and equity get joined at the hip in terms of the design. It's a way of having progressive, universal healthcare coverage, if you want, for immunization in neglected communities. So we're going to hear about approaches that are participatory, that give some power to communities, but it's not, and that use data and that use monitoring, but they're not primarily counting and registering children. They're really a primary healthcare, community-based primary healthcare approach that does all of the above. So we're going to hear from some experts about that. And in the last invitation we resent, you had the bios of all our speakers. So I will not repeat them because it would take a lot of time, but they represent broad experience, depth of practice and research in strengthening community inclusive systems for health, with some of them specific focus on immunization, and all of them an understanding of immunization and primary healthcare. So we will first hear from Professor Henry Perry, which I'm sure some of you know from Johns Hopkins University, who has done numerous publications on these topics, and he will summarize a bit the evidence and the history for us. Then we will hear from two colleagues from the NGO world, Tom Davis at World Vision and Phil Moses at Food for the Hungry. And both of them have high marks in their experience. And there we speak about an approach that's called the care group model that's integrated, but they'll speak to us about both the integration and the impact for immunization and zero dose. And then we'll hear from someone that I'm sure many of you know, Lora Shimp from JSI, an old-time friend of Gavi and part of our demand hub. And she will speak to us about My Village, My Home. Very interesting approach at first. So for the interest of time, thank you. We've committed 90 minutes, which I realize is a lot. We are going to first hear the, 3 presentations in a row. And I encourage you to, write your questions in the chat. I think we're expecting a number of people. We're about 50 already. So we won't have people raise their hand and ask questions verbally. So please put your question in the chat. We will facilitate. I will facilitate the first half. Then Smita will take over the Q&A and facilitate. We will feed her the questions to her. And then we want to think practically about Gavi as leading investments for zero dose. And so after the Q&A, we'll have a quick listen back session where two of our senior country managers, and we really appreciate that Suleiman and Ricard will come as respondents. They haven't prepared anything. I don't know what they're going to say, but they're going to listen, participate, and kind of give us a feedback from their position as being kind of the key control mechanism and management for Gavi. And then Ranjana Kumar, who, as you know, does lead work in the Zero Dose Working Group and leads our team in HSIS. Ranjana will give us a quick word of conclusion and try to think about what does it mean for Gavi, what we've heard, the pros, the cons, in terms of how we structure our opportunities. So without further ado, I'm going to let Henry take over. And remember, just put your comments and put your questions in the chat, and we'll process as many as possible. And what we can't process, we'll try to have a follow-up after that. So thank you very much. And Henry, thank you very much, and over to you.
Eric, thank you so much. Good afternoon, everyone, and good morning. Thank you so much for inviting me, Eric. It's a great honor to be here to share some ideas that are dear to my heart that have focused my life's work. And I want to talk about census-based approaches as an entry point for primary health care, including immunizations and identifying zero-dose children. Next slide. So what I want to talk about first is census taking and routine systematic home visitation, and how that has led to something we call CBIO. And then I'm going to introduce the concept of care groups, which I refer to as CBIO Light, and also mention something called Pro-CCM, which is proactive outreach for community case management. And then give you some examples of these issues, and including the civic engagement piece from the Core Group Polio Project, and mention a very impressive project that BRAC has been conducting in the urban slums of Bangladesh. Next slide. I've had the great privilege over the course of my career now to have been connected with friendships and mentorship with John Wyan and Carl Taylor. And their mentor was a man named John Gordon, who worked with the Rockefeller Foundation in the 1930s and started a process of visitation of all homes for surveillance purposes. John Gordon later became professor of epidemiology at Harvard School of Public Health and mentored Carl and John. And through these two people, some amazing projects emerged at the Hospital Albert Schweitzer in Haiti through the Bergrens and their later work at Save the Children, at the Matlab field site of ICDDRB in Bangladesh, the Arolis work in Jamkhed, India, the Bangs pioneering work in India also, and then my own work in Bolivia in the early 1980s. Next slide. So through all of these emerged a set of principles that we were able to consolidate into a paper that we published in 1999, which goes into quite a bit of detail about a whole framework for working with communities to improve health, based on determining what the community's priorities are and what the epidemiological priorities are based on locally acquired data, and relies heavily on community engagement and community partnerships, as the title mentions. I'm still passionate about this, but it never has made it into the mainstream for lots of reasons, but it's a very holistic long-term approach that just hasn't fit into our global health paradigm yet, but I think there's reason to hope that this will gain traction over time. Next slide. As I mentioned, home visitation is a critical part of CBIO, and then emerged somewhat separately, not directly from our work, but this idea of the care group, which Tom Davis and Phil Moses will talk about more. But this is a very powerful approach that has spread very widely throughout the world, mostly through the NGO community. But it involves volunteer women who each take responsibility for 10 to 12 households. And then these women who are volunteers meet together as a group of women, 10 to 12 in a group, and they meet with a promoter or a community health worker who give them messages to share with the households. And so through this cascading process, it's possible to reach every household every 2 to 4 weeks through a volunteer and share messages which relate to maternal and child health, and immunizations has certainly been a part of this. Go on to the next slide. So we've published several articles on this, but you can see in the bottom here that the under 5 mortality in care group areas declined by an estimated 32% compared with 11% in areas with child survival projects not using care groups. This was an analysis of USAID child survival projects that had been conducted in the last decade or so. Next slide. I wanted to mention briefly one of a number of care groups projects. This was a pioneering one that I had the privilege of evaluating back in the early 2000s that served a population of 185,000 people in Cambodia. Next slide. So this is an example of one of many dramatic improvements in child survival interventions that were achieved by this project. And I wanted to highlight a few things about this. Number one, you can see that there was a rapid uptake of immunization coverage starting from very low levels that exceeded by far the levels that were in existence at that time on a broader scale in Cambodia. You can also see that the coverage was maintained once it was achieved in the original area. And the other thing is that there was frequent measurement of coverage, which was possible in a very simple process that care groups make possible. And that is something called a mini MINI KPC, which was conducted every 6 months or so through the care group process, but by the supervisors of care group projects randomly visiting a small number of households to assess the coverage of immunizations and other interventions that were being promoted by the project. Next slide. So this is an example of the power of this approach, showing the decline in under 5 mortality that was achieved by this project. And that mortality was measured by vital events, which are reported by the care group volunteers themselves. So it was inherently built into the system, a very inexpensive and a very powerful way of tracking in real time the mortality within the population area using local data. Next slide. So I wanted to quickly mention a variation on this, which is emerging, which is very powerful as well, which is also based on frequent visitation of homes. That hasn't been used for immunizations yet, but it certainly could be. This is called Pro-CCM. It's based on community case management, but it's been pioneered by Ari Johnson in Bamako, Mali. But as you can see here, they used paid community health workers to visit homes frequently, and it's been focused on management of diarrhea, pneumonia, and malaria. But you can see that they have reported an under 5 mortality rate of 7 in peri-urban Mali, and there are other groups that are replicating this. And there have been publications on the use of this for malaria programs that have been very impressive in their achievements. I was in touch with them yesterday, and they are very proud of the fact that in this program in Mali, they have achieved a 30% immunization rate against COVID, which is much, much stronger than what's been going on in Mali more broadly. Next slide. I wanted to mention the Core Group Polio Project. I'm sure some of you have heard of it, but perhaps not all of you. But I think their experience has a lot of relevance for what Gavi is addressing now in its challenges in future programming. And I know that Lee Losi, who has been directing the technical work of this for a long time now, has had a chance to share some of this experience with you. But there are some important features of the Core Group Polio Project which are relevant for your interest in zero-dose children. Next slide. There are 3 articles in this journal supplement which I helped to produce. One of them is a very powerful article by Roma Solomon about how in India they were able to achieve very strong community engagement for addressing polio problems. And as you probably know, the Core Group Polio Project was only brought in to work in the very difficult, hard to reach or resistant areas of the world where polio transmission had not been stopped. And so in India was one of the great early successes of controlling polio within the country, and the Core Group Polio Project was given a lot of credit for that. So the strategies that they use there have been described in this paper by Roma that focused on community engagement and the role that NGOs can play in strengthening government activities. There's another very powerful article in there about how the census-based approach was used for an information management system that helped to identify all births and through that to identify children in need of initial dose of polio, which will be very relevant for your work. And then the final article in the series are the lessons learned from the Core Group Polio Project for other global health priorities, including immunizations, but going far beyond that as well. Next slide. So I wanted to also mention the BRAC-Minoshi project. I'm sure most of you have heard of BRAC, the world's largest and by many standards, the best NGO in the world, working in many countries now. But in Bangladesh, they initiated a maternal and child health program in the slums of various cities around Bangladesh, reaching 8 million people. And they were able to develop a census through engagement of the community, develop a program for visiting all homes. It was not focused on immunizations, but the whole principles are very relevant towards strengthening immunization programs, but also towards building a more comprehensive, integrated approach to health priorities. Next slide. So in conclusion, I want to emphasize that it is possible to take a census and to develop a system of routine, systematic visitation to all homes. And it's a very powerful approach to strengthening primary healthcare programs and at the same time identifying zero-dose children. It can be done with minimal numbers of paid staff or perhaps, but not necessarily with larger numbers of minimally paid staff. The Care Group Project is a great example of how to use volunteers to achieve this outreach. The Core Group Project has used more minimally paid staff. It lends itself to building an integrated community-based platform, and other interventions can be readily added to it. And the more interventions that are brought into this, it makes it much easier to engage the community in this process. And that was one of the lessons from the core group polio project. Just promoting polio by itself tended to alienate the community, but expanding it to other activities and routine immunization was part of it, but other maternal and child health activities also strengthen the ability to work with the community. This whole approach also lends itself to vital events registration. And I think there is a lot of potential for engaging communities and helping them understand what the rates of mortality are in their community and what the causes are to bring them in as partners in this process. This cannot be done without strong relationships with communities and partnerships. And the Core Group Polio Project has been a real pioneer in bringing in the NGO community to work hand in glove with governments to achieve these kinds of purposes. Next slide. So I wanted to end on this, what I call the virtuous three-legged stool, which guides
Maybe
my
briefly,
thinking every
Henry.
day. What's that?
I said briefly then the stool, Henry.
Yeah, I'm over time. So maybe in my wrap-up comments, I might say a little bit more about this, but there's a lot of power here in strengthening vertical top-down programs with services-oriented programs and community-oriented programs that work with communities to help them improve their health. And unfortunately, we've been living in a world where vertical top-down programs have driven so much of global health. So thank you.
Thank you so much, Henry. Sorry for rushing you. So we've heard about broad features that I've shown in different settings, different designs to show impact. And we're going to hear now about one particular approach that Henry has mentioned. So Tom and Phil, I yield the floor to you for about 12 minutes, if we can, on the care group approach. Thank you.
Start. Next slide. So let's begin with a few more details on the care group approach structure and what happens during its use. So with this approach, you start with a census which targets either all households or every household with a beneficiary, like pregnant lactating women and children under 2 or under 5. So there's a flexibility in terms of which households you include. Next, the care groups and the caregivers in each group of 10 to 15 households, if you see the right side of this graphic, select a second tier volunteer community health worker who will serve them. These care group volunteers are then trained every 2 weeks in groups of about 12, either by a paid care group promoter who works with about 5 to 9 groups, or a first tier community health worker who only works with 2 groups of volunteers. The groups of volunteers are the care group, and the groups of caregivers are often called neighbor groups or neighbor circles. The care group promoters are supervised by a supervisor, and when a community health worker is in that care group promoter role, they're usually supervised by health facility staff. So the care group volunteers learn a new behavior promotion lesson every 2 weeks, and then they cascade that down to the households that they serve. So it's essentially a behavior promotion platform. Next slide, and over to you, Phil.
Thanks, Tom. Good day, everybody. I'm Phil Moses. Yeah, let's look for a moment at some of the program design features of care groups that promote full inclusion and equity. To start with, care groups is a multiplier and a cascading model. It expands the reach of the first tier community health workers, allowing them to reach many more households much more frequently at a lower cost via volunteers. It's also a push rather than a pull model. It uses a combination of home visits, group meetings, which are flexible, to assure complete coverage with home visits to defaulters. This also helps you to reach men, mothers-in-law, and other influencers at the household level. The contacts received by caregivers by their care group volunteer is constantly tracked, so you can know if you're getting the coverage you need. The caregivers and households with the most vulnerable children or other targeted children, such as zero-dose children, receive additional home visits by the care group volunteer. It's important to note this is also a peer-based approach. So the gap that you often see between a community health worker and caregiver, educationally, geographically, culturally, is smaller, which may assure better reach and better relationship. It's also, I think, notable that each caregiver receives about 20 to 26 contacts per year from her care group volunteer as part of this integrated approach. So this model gives more and more frequent opportunities to refer and convince caregivers to get their children vaccinated. Right? This is compared, for example, with the timed and targeted counseling model from World Vision, which calls for 9 household visits. In many care group projects, promoters actually track data provided by the care group volunteer on a smartphone. And in areas under COVID restrictions, where phone penetration is high, care group volunteers have been using phones to receive orientations from the promoters, which they then share with their neighbors and send their data back to the promoters. So thanks. Let's go to the next slide. And Tom, I believe you're up. Thanks.
So let's talk now about how care groups have improved immunization coverage. First, it helps you to identify children needing vaccination and increase immunization demand. Combined with barrier analysis formative research, which is recommended in the care group training manual, you can specifically identify and target the most important social and behavioral drivers of vaccine uptake in a given area. Barrier analysis is often used in tandem with statistical household surveys to help explain why targeted practices are found to be low. It also helps MOH and other stakeholders to be aware of systemic barriers and quality of services through direct and repeated contact with the caregivers and the feedback that you receive from them. So that discussion of barriers they have to the behaviors is done in those biweekly contacts. So they're constantly talking about that. Also, other behaviors and services can be and are promoted through the model across many sectors. Go back a slide. Zero-dose children are also probably missing out on many of these other services, and care group volunteers often support immunization service delivery through community mobilization, helping to update MOH registers for outreach, and identifying zero-dose children. And lastly, we've had excellent outcomes in other sectors such as nutrition, WASH, and child protection. And when you receive these slides, you can click on those links to get a bit more information on that. Next slide. This graph shows the baseline to final changes in the proportion of children fully vaccinated in 8 care group projects with an average indicator gap closure of 40 percentage points. So gap closure is a simple calculation that shows the increase in an indicator based on what was possible at baseline. So a change from 20 to 40% would be calculated as a 20 percentage point change divided by a possible 80 percentage point change given the baseline, or an indicator gap closure of 25%. Gap closure gives a much more nuanced view of results than simple change in percentage points, since going from 85% to 95% coverage might take as much effort as going from 60% to 85%. Next slide. In this unpublished analysis, we compared 4 care group projects to 9 other very intensive community-based primary healthcare projects with the same donor and similar project inputs. And we saw 32% better gap closure for DPT3 and 28% better for DPT1. This gap closure also compares favorably with the Gavi-wide objective of reducing zero dose by 25%. Note also that the gap closure for DPT1 was greater than that for DPT3, demonstrating that impact was achieved with accelerated equity. Next slide. So we notice in a large USA data set that Henry mentioned that the care group model seemed to be outperforming other child survival projects in terms of indicator changes. So in this 2015 study, we compared the effectiveness of multiple care group projects in 5 African and Asian countries to other USAID-funded child survival projects that did not use care groups. We looked at adoption of 15 key child survival behaviors and services and the effect on the under 5 mortality rate. So we had 10 care groups compared to 9 non-care group projects, and they were matched by country and year of program implementation, and they all had similar budgets. Through that, we found that care groups outperformed on all 15 indicators, including measles and full vaccination, and had double the behavior change of non-care group projects, and may have had 53% greater under 5 mortality reduction, although that wasn't statistically significant at the p is less than 0.05 level. This matched the performance trend we'd been seeing with larger data sets. Next slide, and over to you, Phil.
Thanks. Yeah, let's look for a second at what's needed on the health system side to ensure the maximum results from using the care group approach. Since this approach increases demand for immunization, the health system needs to have the capacity to meet this increased demand. And now, if that's not the case, then the system needs to be improved concurrently through wraparound activities at the health facility level, such as, for example, an improved cold chain. Now, while not an intervention, it is good to pair care groups with a corollary monitoring system, for example, one using lot quality assurance sampling, or LQAS, or other monitoring and screening tools. This is for two purposes. One is to prioritize geographical areas where care groups should be set up, for example, where there's poor equity, lower vaccination coverage, or more zero-dose children or mixed communities. And two, to identify those areas where immunization rates and equity are not improving fast enough. For example, LQAS was used in a large Mozambique project very effectively to identify care group service areas that were not improving quickly enough in service coverage, so that additional activities could be added specifically to those areas. The approach does require supervision of the community health workers who are promoters. This is often done by Ministry of Health staff or NGO staff. And the care group approach only requires a low level of literacy on the part of care group volunteers. For example, in the Mozambique project, only about 21% of the care group volunteers were literate. This can be a huge advantage in many fragile settings. Next slide, please, and over back to you, Tom.
So let's talk about care groups and country ownership and sustainability. This approach can be part of how the health system operates sustainably. The care group approach has already been used by 32 organizations in 42 countries, with many of those applications being to increase demand for vaccinations and other health services, demonstrating its wide applicability in many settings. The model has been scaled in Malawi by the Ministry of Health. It's been adapted in Ethiopia, and there's interest in Senegal in scaling it. Smaller care group projects have generally reached at least 50,000 mothers and children, and larger applications have reached over 200,000 beneficiaries and about half of all the districts in a province. And we definitely see some better cost effectiveness, the larger groups that you're trying to reach. The model is polyvalent. It allows the Ministry of Health to increase service demand and care seeking and achieve multi-sectoral behavior change with the same platform. The graph on the right shows just one example of how we have seen health facility usage and service demand increase, in this case for institutional deliveries, after care groups were introduced. The pink line is in areas that were not using care groups. This graphic shows the change in facility-based deliveries over the life of care group project. And you can see that we saw much better change there on where we're using care groups. Next slide.
Thanks. Yeah. So another aspect of the care groups approach that contributes to its sustainability and scalability is its low cost. The average cost per beneficiary per year of projects using the care group approach is in the range of $3 to $8 US. And these rates were for projects that often covered multiple sectors, not just one area. On a per capita basis, the large Mozambique project cost about 54 cents per person per year. The cost per life saved with care groups ranges from about $440 to about $3,800 US. And the cost per disability adjusted life year averted varies from about 15 to about 120 some dollars, which is actually a fraction of the WHO threshold for highly cost-effective interventions. The cost per case of malnutrition averted in the Mozambique project was $138. Now, preventing malnutrition, of course, is often an intensive process involving the changing of daily habitual practices, often among multiple household members. Impacting more occasional behaviors, such as bringing a child for vaccination, might be less intensive and might be less costly than that. Thanks, and over to you, Tom.
Sure. So one of the things that always impressed me the most about this was the sustainability studies we've seen early on. Sustainability studies on care groups by World Relief and the researcher Halkan Utura found high sustainability of outcomes. For example, World Relief found that 93% of care group volunteers were still active 20 months after the end of all project funding and project activities. And half of the women in communities have received a visit from the leader mother, the care group volunteer, in the past 2 weeks. Measuring indicators at 2.5 and 4 years post-project found that all results were sustained or improved. This graph shows the increase in the percentage of children fully vaccinated in the project from baseline to final, and then maintenance of the rate above 90% at 36 months post-project. A separate study by Tura in 2017 in a different area found similar results. So this could really help Gavi with transitioning. Care groups have been used in development, rural, urban, and fragile and emergency contexts. And I've linked to a few examples of care group projects in those settings on this slide. Thank you very much.
Thank you, Tom, and thank you, Phil. This has a record-breaking coverage of a lot of material. I appreciate how much we're packing today. So we heard from, the care group, a lot of rich data about that. Please keep writing your questions. And now we're going to switch to another model, which I think has similar features of engagement and data, but which has been developed in the world of immunization. So I will ask now Lora to take the lead and share her presentation on My Village, My Home. Write your questions and we'll move to the Q&A after this. Thank you.
Hi, thanks. And thanks, everybody. So yeah, what I really want to emphasize as I go into the presentation is the concept behind community engagement and ownership that has been part of this process for immunization strengthening, using a tool as part of a process, an array of tools called My Village, My Home. But I'll put that in the context also of other tools that have been part of this more organic process that we've done over time to really emphasize that community piece. On this slide, you see what the tool itself more or less looks like, which is after a birth, so pregnant women are met with community health workers. When that birth is registered or when the baby is born, that name is entered onto this list of this house, the idea of the whole house being the village or that community. When each child is listed, then the community health worker with this visual model that is usually posted at a community health center, in a village leadership area in the community. So it's not at the facility, it's out with the community in a recognized open space. And then each antigen that child received is then listed on this My Village, My Home line, so that as the year progresses, you see the bricks come together so that the whole house is constructed. And then when there are missing bricks, there's a way to identify what antigen has been missed, triangulate that with the health worker to get the vaccine provided. And then also that community engagement to say, someone is missing their services, how do we engage them? Next slide. What I'll talk about a little bit is this grew out of the concept. Those who have worked in India have heard of the 3 A's, the Anganwadi worker, the ASHA, and the A&M. And really, it's been a process to look at that community piece. What is happening with Anganwadis and ASHAs out in their communities to really link those delivery sites and those interfaces that exist naturally in the system with the A&M and the facility to make sure there's complete immunization. Next slide. So we had done that in a few districts and in both Jharkhand and UP state, peri-urban, rural, not so much dense urban, which in part is because community in a dense urban environment, as we know, can be very different. But we saw it across different modalities and then have worked on it in other countries where it's been adapted that I'll talk about in a minute. So what I mentioned in the beginning around the importance of the My Village, My Home tool with things like vaccination cards and home-based records and that interface between community health workers and health facility staff. There are the data tools that already exist, the registers, the tally sheets and other things. It's that name-based, individualized, community-level tracking that's an important part of this, and that sharing an interface of data to make sure that there's visualization, community engagement and ownership, and that it links back with the tools that the health facility is using to be able to say, are we tracking those children and reaching them? Are there any missed communities? That's where our zero dose appear. If we see that certain members of the village aren't even being recorded, then that's where the zero dose might be. Or if there's a mother that the community health worker has known has delivered and that name of that child is not on there, that's where we enter that information and then follow that child through the system. Next slide. So part of the process in this, and I want to emphasize again, it's many tools. So it's newborn vaccination, it's looking at community health workers, the cards and that process. And it really does link with the reaching every district approaches as well to make sure that we're looking at quality improvement and equity to reach everyone who is considered to be a part of that house, that community. And then the emphasis on understanding the guidelines, the sensitization, the interface and use of tools, which we often see as a challenge, and that on-job capacity building, which you see in this flow diagram, to really make sure that it's part of not only an orientation, but follow-up visits, and that role and responsibility and encadrement, as we say in French, of that community health worker with the facility staff, and then that review process and monitoring process with village leaders and local community members so that they also feel a sense of ownership. Next slide. So I want to just walk you through quickly some of this work that we did in Zimbabwe. In 2017, we were looking in Manicaland province, where there was a high number of under-vaccinated and quite a bit of zero dose, although the denominator issues are also an issue, of course. We were looking at home-based record improvement and My Village, My Home together, based on the experiences that we had had in Malawi, Timor-Leste, and India. And I really want to emphasize here that bottom cadre that's circled. It really has to engage the rural health center nurses, the village health workers, and those village heads. They are the focus of this, not the central level or the national level. They had to be a part of this because that buy-in and advocacy is important, but really it's getting that groundswell of community engagement and ownership. Next slide. And we started in the 2 districts, and then at the request of the Ministry of Health expanded to more districts because they saw the benefits of it. When we evaluated this methodology, this was not designed as an intensive study. We didn't have a lot of money for an intense pre-post test evaluation. This was part of implementation activities that were already ongoing with Red Rec in Zimbabwe. But we did do some randomized rural health center key informant interviews. And again, I'm highlighting that we really wanted to get the caregiver's perspective, the health worker and local village health worker interviews as part of this, to understand their perceptions and use of My Village, My Home, and the concepts behind this idea of full vaccination and making sure that they were addressing unvaccinated children as well. Next slide. And so this, you see here the tool in action. This is a village health worker with her ZEPI register, which is the official register for the Zimbabwe EPI. And then of course the hand-drawn maps and the My Village, My Home tool. Next slide. So the findings that were important, and again, this was a short time period. This was not a 3 or 4 or 5 year intervention. This was over a 2-year period. So longevity is also important to see if these things stick in a sustainable way. But what we did see is there was improved understanding of the caregivers about the importance of the home-based record, the card, the child health card, which had often been underemphasized and in some cases not even available. So that alone is one tool that should always be available, and they're integrated tools. So if growth monitoring and other interventions are with this, ideally this is an integrated process where you measure immunization, but you also get the other services that are supposed to be part of that. But where we found gaps was in health worker and community health worker communication around due dates. When do I come back? Where will I get that service? Is that service going to be there when I go? And we've seen a lot of issues with this in Kenya and other places where stockouts of vaccine or delays in outreach visits cause those disconnects. So we have the motivation and the engagement of communities, but that the service delivery side has to match. Particularly important on the bottom part is the village health worker perspective too. They now felt they were able to reach more children because they had this tool to help guide them in that process. They also were conducting more defaulter tracking. They were updating the register. They weren't previously using their ZEPI register very effectively. So that was something that was mandated by the ministry, but not very well supported. So that's something also that became more part of their day-to-day work and understanding of what that component was. And then the village health workers also noted when there were missing bricks, they could identify who by name and rationale was missing. And engaging the village health heads, the village heads, they were able to actually identify people by name and know exactly as the village leader why that person had missed their vaccination. Had it been caregiver on travel, someone had moved away, or other lack of knowledge or sensitivity issues that the village heads could also help to address. Next slide. So in terms of numbers that we saw, you can see between the 2018 and 2019 period, we did see in some of the district in the project district areas in the 16 when we expanded, you saw some increases in 0 dose being reached. But what I want to emphasize also, these are percentages. And as we know, denominators are issues. And oftentimes we have challenges with what's in the numbers versus the percentages. So it's often very important to compare numbers vaccinated with percentages, because you see there that sometimes the percentages can be misleading. And it's really useful to follow this over a trajectory to see if in fact the initiatives have stuck. 1 year's coverage improvement for 0 dose is not an indication that that's a sustainable program. You need to see that over time, which is something we've also been following in Zimbabwe now in 2020 and 2021, including with the PEF funding. Next slide. And here, this is a perfect example of the denominator issue. Just look at UMP and Cheretse, and you see when we started, they were negative dropout, then they're high dropout, which, somewhere in between is the reality. And this is really part of the challenges we face around the uncertainty of not only denominator, but also we are finding with DHIS2 and other considerations that children who are receiving measles after 11 months of age might still be counted in the DPT rates for measles, for example, or for DPT3, but meanwhile, they are outside of cohort, and that creates a negative dropout. So part of the issue too is really understanding not only are the tools like My Village, My Home helping to identify and triangulate that data, but then are these also matching what is being reported through the percentage systems, in part because of the consolidation of data that then murks the results. But we did see in general a reduction in dropout because of this tool in the community to really identify when children were due and make sure there was timeliness and completeness. Next slide. So just a quick emphasis on Malawi, where this has been done over time. Here you see also the other indicators that have come along. So you see across the board that outreach visits had improved, that there was improved micro-planning and use of micro-planning, and also the My Village, My Home concept as part of the strengthening routine program. So looking at performance indicators over time. Next slide. So the lessons basically, as I've already mentioned, are this does need to be done on a fuller scale. You can do it in localized communities at very low cost, but there does need to be assurance that the vaccination cards are there. There's a minimal cost related to actually production of the tool, the My Village, My Home tool, but those can also be hand-drawn, although it's preferable that it be more of a poster size so that it's more visible and more durable in the location that it's in. This has to be part of micro-planning processes at district and facility levels, and resourced to the extent that you have community health workers who are engaged in immunization, and not just there because they're being funded for measles campaigns or other activities, but truly resourced by the health system. And it also has that emphasis of really community responsibility and accountability, the incorporation of the village heads for motivation, and then making sure that the data issues are also addressed at a broader level because of the denominator issue that I mentioned. Next slide. So in the subsequent slide, and these will be shared with you, we have several links to videos, documentation that's been done across these 6 countries, And as I said, again, this has been part of multiple approaches. So this document, which is in the links, shows you what's been done over time with 6 countries that were supported with USAID funding, including from the MCSP program, the Maternal Child Survival Program. And in the next slide, you'll see the pages of this document. It's, I believe, 4 or 5 page document. The results are summarized by these different category areas. So we talk about coverage, timeliness, target population, that feeling of shared, that some of the qualitative aspects of it in terms of responsibility and accountability. And of course, the key question that always comes up around integration, is this useful for other services? So here's a list of the references. These are all linked. So when the slide is shared with you, you can click on the links and get access to any of the information that's available for the countries, and then the summarized collective learning. And I think that's my last slide. Thank you very much. And there are some supplemental slides that have clips from the video, the Malawi and Zimbabwe videos, and some of the learning. So you can find that there as well. Thanks.
Well, thank you, Laura. Thanks a lot. It's been a whirlwind hearing from people that have a packed amount of knowledge and experience. So I think now I will turn it over to Smita. We can close the windows now, Christine. And we're going to, Smita is going to dispatch some of the questions in the chat, and you can add more. And we're going to have Q&A with our speakers. And I think we're all going to be okay for time for this. So over to you, Smita.
Thanks, Eric, and thanks, everyone. So I'll make this a sort of a rapid fire round, giving the presenters maybe a minute to respond to the questions which I have in the interest of time. So the first one goes to Henry, which is that how strong is the evidence for these approaches, both for impact and equity?
Right. So I would say, as a general statement, these approaches are very powerful, and there's a lot of very strong scientific evidence of their effectiveness. There's much less evidence for their effectiveness applied at large scale. However, the Core Group Polio Project has worked at the level of millions and millions in 10 countries or so. And so I think it is a good example of the broader application of these principles at larger scale. And that's why I think there's a lot to learn from the Core Group Polio Project. These smaller projects that we've all been associated with have convinced us that there's some real value in this approach. And so it's time to take this to a larger scale, and using larger amounts of funding for larger scale programs that could help move in this direction, not only for the vertical program itself for which the funding is provided, but also to make it friendlier to engage the other interventions for synergistic impact. And I'll try to come to that at the very end in my closing comment.
Thanks, Henry. So a couple of questions for Tom and Phil. There are a number of questions around, financial and non-financial incentives. So one of the questions which stands out is regarding the non-financial incentives for the volunteers who are who visit the households to participate in the core group program. And I'd request Phil and Tom to talk about this.
Go ahead, Phil, if you want to start, and I'll tag team with you.
Sure. I think this is actually for the, in terms of incentives, I mean, this is really based on Wall Street research, basically, that people work, what motivates people is being connected, being appreciated, and mastery of new material, new knowledge. And I think that's been those are the 3 things that have been most fundamental to keeping volunteers engaged and active. Tom, you want to jump in on that one as well?
Yeah, sure. One thing we did, both focus groups and then larger surveys with the volunteers after the big Mozambique application. And what we heard when we said, why do you do this work? You weren't paid. The only thing they got was maybe a wraparound skirt with some key messages on them, maybe a pair of boots one year, but very little. We did keep, one is it wasn't that time consuming. The amount of time they needed was only about 6 to 8 hours a week. And also they said we're better respected. 100% said by other women, About 63% said by their husbands, another 25% by health facility staff, and about 30% by people and the community leaders. So that high level of respect they got is the number one reason they said they did this work.
Thanks.
Yeah, let me
Thanks.
add, can I add another quick comment to that?
Yes.
One of the other features of this, which makes it so compelling, is that by virtue of the fact that these women in a care group are meeting frequently, every 2 weeks they get together and they learn from each other about their previous experience and how to do better what they are going to be doing the next time around. And over the course of time, this becomes a very empowered group of women. And so the women's empowerment component of this, and we know this happens in a lot of other self-help groups that are composed of women, but the empowerment component of this is quite impressive as well.
Thanks for that, Henry. So a couple of questions again on context. There are questions around urban setting and, homogeneous and heterogeneous characteristics. And the question is that in which context do care group models, they work the best? And does history of trust or solidarity in the group, does it matters? And what are the other socio-political contexts which matters in forming the functionality of the care group? And a second question, which I'd sort of tagged to that, is around the capacity building approaches of the care group model, and especially in, say, low literacy and fragile context. So anyone who would like to respond to this, please go ahead. But
I'll
please make it quick. Thank you.
Sure. So we've seen better results where there's a high level of trust and social cohesion, but also these care groups help build that social trust, that social cohesion and trust. Another thing that we found is it generally works a bit better in areas that have decent population density. We wouldn't recommend it, for example, for the Bolivian Altiplano, which is very low population density.
Yeah. Also, just to tag onto that, one example in Guatemala, in the highlands, where there was a history of a long civil war, there was strong distrust among different groups. So Cura Americas initiated a care group project there. It was slow starting, but after a couple of years, they actually were building ties and trust across these groups that had been quite distrustful of each other.
Thanks.
So,
Thanks for that.
if I can make another quick comment. So the application of care groups in urban informal settlements is limited as far as I know, but I wanted to go back to my mention of the BRAC Minoshi project. And in that case, in the urban slums reaching millions of people, it was possible to conduct censuses and to carry out routine visitation of all households. It wasn't with the care group process, but the basic principles were applicable in an urban informal settlement.
Thanks. So, Laura, would you also like to add to this, considering that GSI works in urban slums in Haiti? So that is one question for you. And secondly, if we have to talk about My Village, My Home, so the interoperability of the entire, sort of bigger machinery which works around that, would you like to talk about what it takes basically to get it moving?
Yeah, thanks. And I think the urban context, it is a really, community engagement in the urban context has to really be locally identified. I mean, we've been seeing, even with urban work in Kinshasa, for example, and Haiti, certainly, from one community to a next, from one district in an urban environment to another, the community engagement might be very different because it's a community that's focused around a couple factories versus a community that is more peri-urban, but has urban elements to it. And your approaches are going to be different in those places because if you're around a factory, for example, you may be seeking health services, not at the facility that's closest to you, but to a facility that's on the other side of the factory in a different district. And therefore your sense of community is different as to what it might be in more of a rural setting. And it's important to understand that. It's also very important to understand how community, well, in DRC, we call them relais communautaires, which are the community mobile, the community networks, how they function in those different environments. And that's where, to the My Village, My Home, it may not be as applicable in an urban setting where that community, you would have a lot of missing bricks because those caregivers are seeking services elsewhere. So part of the understanding of which approach you use relates to what that sense of community is in that environment. So My Village, My Home could work in parts of Haiti or Kinshasa where there is more of a sense of we go to the same facility for our services. But in mobile populations, like we've seen with UIFHS in Ethiopia, My Village, My Home would not be a tool because they go to 3 or 4 different facilities in a time period. That's where the card becomes so essential. Because if they don't have a card, you don't know if that child has received their previous dose because the family folder is back with the facility somewhere else. And that facility person is not going to call and track down to find out if this is DPT2 or DPT1 or DPT3. So part of it is really that interface that's important. And for the My Village, My Home to work best, it is when there is that sense of this is our community. We define our community based on this health facility catchment area. And then this is how we interface with the village, with the community leadership, and with our community health workers to make sure that that linkage is happening and that we're all referring to the same data and that we trust each other with that data. Because a lot of times the feedback that comes, particularly through digital systems, doesn't reflect the reality of local census and local information because the numbers might be completely different given population movements, given old census data and percentages that have been allocated without really understanding the local reality of what the population is.
All right, thanks for that. And another question for you, Laura, and maybe Tom. So gender has been elevated to a principle in Gavi 5.0, and we were very keen to understand from you both that how do you think that these approaches work in settings which are very, very patriarchal and male dominated, where the decision making processes are pretty much skewed. So your response on that, please.
I know care groups have been used successfully in many countries that are quite patriarchal, such as Afghanistan, Iraq, Sudan, DRC, Peru, India. And in one of FH's Mozambique care group studies, we found that at baseline husbands were a bit resistant to some of the messaging they were being given, like to take children as soon as he found that they had a danger sign, to take them to the clinic, even if they were out of town, for example, working in Zimbabwe. But we work with the men, and we do feel like you can transform gender norms and can transform some of those, the way decisions are made at the household level. And Phil, I don't know if I think you guys have had some experience with that as well, right?
Yeah, in Ethiopia, for example, what we do is every month or so, we also have another meeting with the men of the households to share the same messages that have been shared out. And that's going to get them on board, give them a chance to ask questions, and that's been quite helpful.
From the My Village, My Home and the data visibility side, in some ways it's gender neutral in the sense that the focus is on the infant, not who's bringing the infant. So, and the importance of it is that, as I said, that visible posting in a community place. So it's at the village head's place or the community health center, which men will go to as well. And in many cases, when you have village leadership that is male, as we saw with their engagement, they also then become good advocates and representatives to the communities that they interface with. And that's why this idea of the village home is so important, because it's not just about the female caregiver going to the female health worker. It's about that sense of this is our community. If we are fully vaccinated, we have a strong house. And that involves male involvement just as much as the women who are part of the health system.
Okay, thanks for that. Another question for Tom. So for the care groups, were there any assessments conducted to understand the drivers of motivation for the volunteers to implement activities despite no financial incentives being provided?
Well, I mentioned that example of the focus groups that we did at the end, where we heard mostly about that level of respect that they're getting. You will hear from care group volunteers anytime you visit a community and you're rolling your van in. We would like to be paid for this. However, I would note experience of World Vision had in Uganda, where in one area they decided to pay volunteers $1 per lesson. Immediately, other women are saying, "Why are you paying the volunteer and you're not paying us to show up at the meeting?" All these jealousies created. The volunteers saying, "Well, if you're paying me, you should pay me a lot more than that." So they basically crowded out those intrinsic motivations. So after those experiences, we said, look, women at the end of this say they love it. You have a 4%, 5% dropout rate every year. Something good is happening that they really enjoy. Let's keep the workload light so that we can keep them as volunteers.
I would also add to that really briefly that in the implementation, it's important to ensure that you go out of your way to ensure that the volunteers feel connected, that they feel appreciated, and they are really learning new material. And sometimes that gets pushed by the wayside.
All right, great. And perhaps, in the interest of time, I'll just take one last question, which is around what do you guys think? Are these approaches too expensive to expect, sustainability or even scale up through the national health systems? What are your views on this?
I think the sustainability studies that we presented on the care groups are not outliers at all. I think we often see that the results and the volunteers going on actually promoting behaviors for years afterwards is common. And so it is something that even if the community health workers that work with them don't teach new lessons, it will continue. Now, even better, if you have community health workers connected to the MOH, it will continue to occasionally meet with them, check in. But no, I feel like the cost and the cost effectiveness is excellent with both of these, actually.
Yeah, and I would add specifically cost effectiveness. I mean, if the idea is to improve or to reduce zero dose children, okay, how many children, how many zero dose kids actually are reduced by what you're doing? You could do a very cheap radio program, but is it actually going to reduce the number of zero dose kids?
Well, and particularly, Phil, I think that's such an important point on the individualized nature. There's a lot that's done in kind of mass communication, but that doesn't tell me as a mother or a father when I have to go and where I have to go to get my services and if they're going to be there. A lot of times these announcements are take your child for immunization. Well, that doesn't affect a result to me. And that's, as I presented in the Zimbabwe data with the cards, they have the card, but if the due date's not written in, they may not automatically know that they're supposed to go back on November 22nd to get that vaccine. They know they have to go back, but there's that informational piece that has to be there, which community health workers and caregivers can help interpret if they also are familiar with the schedule, the requirements, the contacts, and when the services are going to be provided. And I think from a cost perspective, from our side, part of the reason we did the My Village, My Home, or didn't do it, was based on how effective that community communication and engagement is. If there's already a good sense of knowledge sharing on the schedules, the health worker communications, and the due dates, you may not need a tool like My Village, My Home because the parents are well informed. But when you find that outreach is irregular, or if there's a sense that there's a village that's not being served because they're on a border between two facilities, that's where these types of tools really help, because there has to be that recognition that the service side and the community preferences need to meet. And that's really where these different types of tools and groups can be helpful. But on the cost, a key aspect too that we've seen with community health programs is if they are getting financial incentives, then that really has to be looked at strategically, because that's where we often see it fall short in immunization, because they've monetized campaign engagement and not routine engagement. The health workers, the community volunteers don't want to work for routine services because there's no financial incentive for them. When it's really related to that community health worker's sense of responsibility across health interventions, that's where the cost is minimal because they have that sense of responsibility. And that's really what we need to be looking at in terms of that empowerment at community level, that incentives are also being recognized, being appreciated. I'm a leader in my community. It's not all about whether or not there's a financial incentive.
If I could add another comment to issues of cost effectiveness and the feasibility of scaling up. I didn't mention in my presentation earlier, but perhaps I should have, but Ethiopia has some important lessons here. Their health extension worker program, which began in 2003 and rapidly scaled up, in fact, is a census-based approach. They have been able to create a map with all the households, and they have a health information system at the health post that serves 5,000 people with 2 health extension workers. They have a health information system in which there's a family folder in each village numbered by the house on the census for that. And so those are maintained in the health post, but the health extension workers go out into the community and they have this information about when children need immunizations and so forth. I'm not able to say that the quality of this has been terrific because I don't know of any serious studies of it, and I can imagine there are lots of problems, but there has been an attempt and has been somewhat successful to scale this up for 100 million people. And there's a lot of evidence about the success of their family planning program, less so on immunizations, I would say, but it's a good example of how this whole approach could be used, and learning how to implement vertical programs through a community-based primary healthcare platform that's integrated, I think, to me, is the future of where we need to be going, and it's particularly relevant for immunization. So I think what we're talking about is very powerful and needs careful consideration.
Thanks, Henry. And I just have one last request of an answer, after which I'm directing to Tom, and after which we'll move and have the reflections from the Gavi senior country managers. So the question is that, do you have any experience using the care group strategy in a context of an existing electronic immunization record? So over to you, Tom.
I do not to my knowledge. Phil or Henry, I don't know if you've ever heard of someone using this alongside of that. It'd be an interesting thing to test. Also considering, there are places where the care group volunteer literacy is quite high. Like we did a test in Ghana, and I think in Zimbabwe might be another place. But yeah, that would be a one consideration if one was to test it for that purpose.
It'd be great to test out, but I'm not aware of any places where this happened.
All right. I think then there are quite a number of other questions, which we will try to respond over emails to the respective, attendees. So thanks everyone for this. And now I'd like to sort of call upon Ricard, who is senior country manager in Gavi, and he specializes in fragile context. And after Ricard, Suleiman, who is the senior country manager for some of the Francophone countries in Gavi. So over to you, Ricard, and then to Suleiman. Just, if you'd like to share your reflections and the relevance of what was discussed right now to the country level work. Over to you.
No, thank you, Smita. No, I have to say, very impressed with the presentation. A lot to interiorize for a late time in the day, actually, and I try to understand most of it. I mean, first of all, very interesting in the sense of our strategy on zero dose, actually. And I found it like really something that we need to dig in at Gavi, actually. I'm actually, while there were the presentations, I was picturing some of the questions that how will I handle that in the countries I work. I'm right now currently working in Afghanistan and Djibouti, right, as a senior country manager, right? One of the things is like the government buy-in. What is the real government buy-in in this model, basically? And it was mentioned about cost effectiveness and proving that the model works with evidence. And perhaps that's something that we have to have ready, at least from the Gavi side on the table, just to show that cost effectiveness. So basically we can really can go beyond being a pilot to something more at a higher scale, basically, which is, you have shown examples in some African countries as well. The other thing that I'm thinking, and the other point, and I think there was mentioning about it, is how the link of the communities with the health system, basically in different areas. No, the referrals, the contacts between one and the other, and also at some point there was mentioning, I think it was Phil mentioning about the data packs that they were using at the community level. Basically, it's like, what happens with that? How does it get analyzed? Does it fit into the health system, into the health facilities? Do they have meetings to say, hey, listen, this is what happened in certain communities. Let's think about it. No, so those are factors to think about it. Basically, you talk about the issues of gender, which I had it in mind as well, and the role of woman. I think it would be interesting actually to see if there is such an analysis. Is like, what is the role of women in these communities, and if women are empowered, or if there is a resistance in women's being empowered in those communities, if them afterwards they are empowered, do they change the results or not? That would be very interesting if we have such data. And I'm gonna stop with the last question, or the last thinking for all of us. It's like, I'm thinking, it's like, from Gavi or from the donor perspective, are we asking the right questions to countries? I'm not sure. Sometimes I'm thinking, yeah, we ask a lot about immunization. We are, oh, what can you achieve in immunization, etc. But I see in your presentations that this is not only about immunization. This is about nutrition. This is about water. This is about malaria. This is about tuberculosis. It's like, are we failing here when we are asking countries to send us proposals about reaching children and zero-dose children? Should we clearly incentivize them to say, hey, we want you to do that, but we want you to do other things, and you will be highly prioritized if that happens, right? So that's, I don't know, I don't have an answer actually to that. That's an open question that I had listening to all of you. And I stop here. Thank you very much.
Thanks, Ricard. Great points, and it really calls for a more deliberation around it, and we'll get there. But with this, I hand over to Suleiman for his reflections.
Yeah, thank you very much, Smita. And let me just start with thanking the organizers and the presenters for a fantastic presentation. And I also want actually to thank some of the participants who have asked actually questions. I was looking at the chat basically. Some key, questions and remarks that they've made that could be turned into concrete recommendation, basically, for us as country, managers, basically. I think from what I heard, obviously the topic of integration and inclusion are not new as such. The concepts are not new, but the two presentations basically have demonstrated that the way we handle them, the way we do them actually on the ground can make such a huge difference. And this is one of the key lessons that I'm learning from that. The care groups and also the model that, Lora, you presented, actually, bring up actually these key questions. And also, one of the things that I wanted to mention also is that, the importance of making sure that we put communities actually into the driving seat is absolutely key. I think Professor Perry, you mentioned it, and other people also mentioned it. It's absolutely important actually to make sure that we work with, but not work for, basically. And this is absolutely important. And this is the way also we're going to answer to the key question that so many people ask. How do we sustain this? How do we make sure that we work with community to raise awareness so that they can own the process and make it sustainable? This is absolutely critical in what we are seeing in the field. And also the number two aspect is the country specificity and community sensitive aspect of it. Basically, if you look at some countries, especially the countries where I work, Niger and Central African Republic, let me take the example of Niger, for instance. Zero-dose actually children, the determinants and the reason why children are not getting vaccinated have kind of evolved. Usually, we are used actually to the fact that mothers are not bringing children actually to immunization. We are quite used to that. But now there are new threats actually on the ground, like the terror attacks actually and threats actually in Niger, for instance, that prevent mothers and women actually to come to immunization. Actually, they are not rich because they're not vaccinated because we cannot reach out to them, but they are scared to get out actually to go to vaccination. And I wonder how this aspect could be taken into account in the work you've presented, and how we can take that into account actually moving forward. It's a burning and important issue that we definitely need to take into account. And to me, actually, as a country, manager, keys basically for success involve actually the ownership, as we said, empowerment of communities actually to sit in the driving seat. But one key important thing is, how do we work with the health system as such? I haven't seen that on the presentation as well. What is the role of district medical officers, districts, regions, and also the central level? Because at the end of the day, even if the community model actually works, we need some bit of management as well. It has to fit into a system. And this system is managed by district, by region, and by the central level. How this aspect is taken into account, because I think it's a key also for sustainability, not only the financial aspect, but also the ownership of the system. And to finish off, and I think how in this particular case, I think one of the participants raised the issue of social, political context, affecting the work of the community workers. I think this is absolutely important for us in conflict settings. For instance, Central African Republic, Niger, we need to see how we do business with communities in such context, basically, because the determinants are completely different. How do we do that? How do we sustain that? I know you said that the cost is not big cost, but still there's a price actually to pay for this work to be done. So how do we make sure that who is paying for what at some point, and how do we sustain that? These are the remarks that I have actually on my desk. And again, thank you so much for sharing that. I can see the upcoming opportunities for us. We do have actually the FPP plan. We have actually some planning coming up, and we are looking forward actually to taking some of these discussions actually on the discussion table with our partners in the field. Thank you so much. Over.
Thanks, Suleiman. Great points from you and Ricard, and it really calls for a bit of more dedicated and purposeful deliberation internally as we, try to systematize our thinking when we talk about reach. And on that note, I'd like to hand over to Ranjana, who is the head of the Health Systems Planning, Management and Performance team in HSIS, and who also leads the zero dose work in Gavi. So Ranjana, any closing remarks from your end here? Over to you.
Thanks a lot. Thanks a lot, Smita, Eric, and to all the speakers. I think it was such a rich experience and presentations that I won't be doing full justice to summarize this. But I think from a Gavi perspective and from a Gavi perspective of next steps and moving forward, what is it that I think we should take into account from this presentation? And I think that will be really important. First of all, I wanted to really thank Professor Henry, because some of those examples that you mentioned, they really resonated to me, because either I have met those people on ground or actually visited those projects. So for example, in Bangladesh, the Gavi board actually had the opportunity of visiting BRAC and the ICDDR Matlab project. So it just came back. And of course, Dr. Bang in Gadchiroli in India and the home-based care for neonatal mortality was absolutely exemplary. Similarly, for Cambodia and the contracting in of services, what you mentioned, again, the Gavi board had an experience of visiting some of those sites and really seeing. So I can see that at the highest level, there is a lot of excitement and enthusiasm within Gavi, but now we have to see how we translate that into actions and investments on ground. The other part I just wanted to mention was that I really appreciated the way the presentations were structured on census-based approaches, care group approach, and then from Lora, the practical program investments in practice. One of the things I realized, and Ricard mentioned it from a Gavi perspective and our program planning, is on costing, sustainability, and are we asking the right questions? And I think Tom and Phil, in your presentation, it was very clear that the costing is actually marginal. It's really a small amount. And I know from the polio program in India that they have an army of, you can call it informers, but they call it field monitors. So this is actually a very low expense, and the government can easily, pick those costs up. But within Gavi, what we see is that we are really supporting the poorest countries and poorest of economies. And most of the health budget goes in salaries and pensions. So it leaves very little flexible amount for programming and on a sustainability base. So they depend a lot on donor funding for those innovative approaches and program design to make that difference. And that's why, the whole lot of incentive on campaigns, because that's how they really, in a cash-strapped government, that's how they sort of survive. But having said that, I think we have an excellent example now within Gavi where we are starting that, additional support for zero dose, starting with the humanitarian partnerships, and which will be for partners outside of the government. And this is really to see how in the fragility context, how we can really start now mainstreaming some of those examples and experiences into a country program, so that we are working synergistically with the government in building all these examples that you mentioned back into the program. My other point really was that I completely agree with Lora when you said that, raising demand has its challenges, because you need to put the service delivery also in place. And Lora, you know very well that with the AAA that you mentioned, the Anganwadi, Asha and A&M model, when India tried to, increase the institutional deliveries, there was a massive demand when those, conditional cash transfers or incentives were used for Asha, but the services, couldn't cope with that demand. I know Gavi is at a very early stage where we are really starting with the demand in Gavi 5.0. And that's an area that we are really, a new area where we are trying to work. But simultaneously, we have to see that in these poorest of countries, those deliveries also need to be there. Like again, Lora, when you said that, well, the date is written, but the vaccine's out of stock when the person comes. So, that shouldn't happen. So I think some of these are really something for us to introspect and come forward. But I'm totally in support of your census-based approaches. I think to identify and plan our services around that is extremely important. The care group approach is also shown, and as you showed in your results, which is that it definitely has a merit in trying. And I know the India polio program really did that. And thank you again for all of you for really an excellent presentation, and which gives a lot of thought for us to look through as we start designing the country programs. And thanks a lot to Eric and Smita for organizing this and managing it. Thank you again, all of you.
Thanks, Ranjana. Thanks for your reflection points. Yeah, a lot of thinking to do around it for, what it means to us at Gavi and how we can sort of, use it. So thank you so much. And I think that we are just at time. So Eric, over to you. Thank you.
Well, I have no concluding word, but thank you very much to all our speakers. Thank you, Ranjana and Ricard and Suleiman. I really appreciate Henry, Lora, Phil, Tom. And there's so much more to discuss, but I think this was a packed session and I think everybody learned a lot. So tremendous thanks for offering all this to us. Have a great rest of the day and end of the day for those on this side of the pond.
Thank you,
everyone, for inviting us.
Thanks for the comments.
Thanks to all participants for the questions.
Thanks, everybody.